Thank you for joining the National Scleroderma Foundation's webinar for today's special event on navigating clinical trials. My name is Angel Soto. I'm the Associate Director of Education and Mission Delivery for the National Scleroderma Foundation. Today, I'm very delighted that we have our guest speaker, Dr. Maureen Mays from the University of Texas McGovern Medical Institute in Houston. We're going to cover a lot of information today, so I'm just going to go over a couple quick points for the event. If you are properly logged into the webinar, you should be seeing the slides on your screen and hearing my voice. Today's webinar is being recorded and will be made available after the broadcast. The National Scleroderma Foundation in no way endorses any drugs, treatments, clinical trials, or studies referenced in today's webinar. Information is provided to keep listeners informed. Because manifestations and severity of scleroderma vary among individuals, personalized medical management is essential. Therefore, it is strongly recommended that all drugs and treatments be discussed with each individual's physician for proper evaluation and treatment. This webinar is for educational purposes only. We also, at the end of the session, we will be hosting a Q&A, and we encourage folks to enter any questions throughout the presentation in the chat, and I will be keeping track of those. So let's get started. I'm delighted to introduce today's speaker, Dr. Maureen Mays. Dr. Maureen Mays is a longtime champion of the scleroderma community who practices out of the University of Texas McGovern Medical School in Houston. Dr. Mays is the recipient of many distinctions and awards, including being named Master of the American College of Rheumatology, winner of the Lifetime Achievement Award from the National Scleroderma Foundation, and is listed in the Best Doctors in America Guide. She is the founder of the Scleroderma Clinical and Research Program in Houston, and her primary clinical interest is in the diagnosis and treatment of scleroderma. She has published over 250 articles and reviews in medical literature describing her findings. She has also written a book for individuals affected by scleroderma titled The Scleroderma Book, a guide for patients and families. With that, welcome, Dr. Mays. I pass it to you.
Okay, well, thank you very much. It's a pleasure to be here, and thank you for inviting me. Let's get started. Let's see. Oh, next slide. Okay, the background in clinical trials, phases of a clinical trial. Phase one, this is very early in clinical trials. This is the first time usually that the drug has been given to people. Prior to this, the preclinical phase, it's given to lots of mice and tested in the laboratory situation on cells. But phase one is the first time in people, and that is in order to determine what dose is safe, how treatment should be given, if it has to be given IV, or if it can be given in pills or by a sub-Q injection. And then phase two, after it's found to be safe and there is a sense of what dose to give, then phase two looks to evaluate effectiveness. Is there a signal that is actually helping in patients? And then, of course, you look for side effects, because phase one tends to be done in a small number of patients, phase two, a little larger, phase three, etc. So after it's determined to be possibly effective and probably safe, we go to the phase three, and that's to determine whether this new treatment is a better alternative to the current standard of therapy. And usually this is what is required to get FDA approval. Then there actually is a post-approval phase called phase four, which is post-marketing. So now this is the phase when a company follows individuals taking the drug, trying to look for uncommon side effects. So things that were not discovered in the phase three trial. And sometimes the FDA requires that a drug company will do a phase four study. So overall, this is an old slide as of January 2015, so now 7 years old. It's put out by the biopharmaceutical research and development process. And so here's basic research, and this is what I was talking about. This is in the lab on cells or in mice. And then there's a whole bunch, hundreds or more, of potential new medications, only a few of which will actually make it into phase 1 trials. And then only a smaller number will make it into a phase 2 trial, and an even smaller number into a phase 3 trial. And then the data are presented to the FDA for review. And to get one FDA-approved medicine, there are hundreds of potential medicines that have been looked at and discarded as not being effective or perhaps being too dangerous or too toxic. So the general design of clinical trials, they have to be controlled. And that means that some of the participants get the new medication and some get a placebo medication, which is dummy. And in most current scleroderma studies, and that wasn't the situation several years ago, but in most current studies, people are permitted to remain on their own background medication. And usually, typically, and I'm sure you all know this, it's mycophenolate, Cellcept, Myfortic, methotrexate, hydroxychloroquine, also known as Plaquenil. So you're permitted to stay on background meds. And then the question is, will this new medication, in addition to the previous ones, be better and not toxic, not causing undue side effects than if you were not on the medication? And then, in addition to being controlled, it is something we call randomized. So whether or not you get the new medication versus the placebo is determined by chance, usually by a computer. And so when we see people and we screen them and they agree to the study and they're considered eligible, then it goes to the computer, and the computer will assign the medication or placebo by chance, like the flipping of a coin. And the final part, usually in these studies, for a phase 3 study, and to some extent also for phase 2, it's double blind. So neither the participant nor the investigator knows which arm a patient has been assigned. So it's not clear if they're on the real medicine versus the placebo. Well, one thing everybody wants to know, and it's an important part, who pays for the clinical trials? Who is sponsoring the clinical trials? Well, sometimes it's a governmental agency like the National Institutes of Health, your tax dollars at work. Sometimes it's foundations or other private organizations like the Scleroderma Foundation or the Scleroderma Research Foundation or the Scleroderma Clinical Trials Consortium. And most of the time for the large clinical trials, because they are tremendously expensive, it's the pharmaceutical companies. So let's go through a little bit of history. Past studies of randomized, double-blind, controlled trials for scleroderma from about 1995 to 2016. There was the penicillamine trial, the photopheresis trial, and interferon, relaxin, oral collagen, TGF-beta, bosentan in scleroderma lung disease, a cyclophosphamide lung study, 1 and 2. Well, and this is now 6-7 years ago. What happened with all of those trials? Some of these medications, obviously, you're not familiar with, and the reason is the penicillamine trial was negative, the photopheresis trial negative, the anti-interferon trial negative, the relaxin trial, collagen, TGF-beta, the build 2, and finally, coming up on 2016, the first lung study, the cyclophosphamide scleroderma lung study, was positive. And that led to lung study 2. In lung study 1, we looked at cyclophosphamide versus placebo, versus really nothing. And people were on the cyclophosphamide did better than the people who were not, the ones who were on the true placebo. And that led to the next study that looked at cyclophosphamide alone versus cyclophosphamide plus mycophenolate, and then the brand name for that, which you may know, may be more familiar with the name of CellCept. And actually, lung study 2 showed that the people on the mycophenolate or CellCept did just as well as the people who were on the cyclophosphamide, but the mycophenolate was safer. There were fewer side effects. And that's why we use a lot of mycophenolate today. So what about more recent clinical trials since 2016? Well, this is the Scleroderma lung study 2. And before we get to that, because several studies these days are looking at scleroderma lung disease, trying to find something that is better than mycophenolate and has fewer side effects. So first of all, what is interstitial lung disease? It's scar tissue buildup in the lungs, usually starts in the bottom of the lungs and then slowly increases up. And not all patients worsen. Sometimes people will start off with a little bit of fibrosis or scar tissue in the bottom of the lungs, and then it stays that way 5 years, 10 years, essentially forever. So not everybody has to worsen. And how do you tell if there is lung disease? Well, usually by pulmonary function tests. And then if the pulmonary function tests look like they are not quite normal, then a chest CAT scan is usually done. So this is an X-ray of somebody with pretty severe lung disease. And if you look at the CAT scan, which gives you a cut through the lungs, this is a normal chest, and this is the heart. This is the spine, so this is the back. This is a patient lying on their back. And the dark part here is the way lungs should be, because this is air, and air tends to be dark on an X-ray. And these white parts are the blood vessels that carry blood through the lungs, the venous blood that gets oxygenated and it's carried back to the heart. So this is the way it should look. Well, if somebody has interstitial lung disease, typically related to scleroderma, this is what it looks like. This is scar tissue in the lung that shows up as white on an X-ray. So there's a little bit of clear area here. There's a little bit of normal lung, but a lot of it is replaced by this scar tissue. And this is area where you're not exchanging oxygen and carbon dioxide. And this is why people get short of breath when they develop scleroderma related or any kind of lung involvement, lung fibrosis. So scleroderma lung study 2 was a randomized, double-blind, prospective, controlled trial. People were given 1 year of daily pills of cyclophosphamide, followed by 1 year of placebo, versus the other people, the other arm, 2 years of this daily oral mycophenolate, also known as CellCept. And the primary outcome measure was the pulmonary function tests at the end of the study. Well, both treatment arms resulted in improvement or stability in lung function. That's good. The imaging looked fairly stable. Now, not everybody got better, not everybody got worse, but in general, overall, both arms, including the cyclophosphamide and the mycophenolate, did pretty well. But as I mentioned before, treatment with mycophenolate was associated with fewer drug-related side effects compared with the cyclophosphamide. And now mycophenolate is considered standard of care for scleroderma lung disease. Well, it might be standard of care, but not everybody gets better. Some people continue to worsen even on mycophenolate. So is there anything else we can do? Well, this led to another study of Nintedanib, and the brand name for that is Ofev, in scleroderma lung disease. This is industry sponsored, which is to say pharmaceutical company, in this case, Boehringer Ingelheim, multi-center, international. I believe there were 70 centers or so around the world, randomized, double-blind, controlled, looking at Nintedanib versus placebo. And the outcome measure, again, pulmonary function tests. And people could remain on their background therapy. If they were on mycophenolate, they could stay on it. If they had been on methotrexate, they could stay on that as well. And then the Nintedanib was added on top of it, or placebo on top of it. And the results were positive. At the end of the study, the one-year trial, there was better lung function in those on Nintedanib than those on placebo. And even if you look at people on Nintedanib plus mycophenolate versus mycophenolate alone, the people on the combination still did better. So that was a win. And consequently, Nintedanib was approved by the FDA for scleroderma, and then in other studies also for other forms of fibrotic lung disease. And Nintedanib is now approved in Europe and various other countries. Well, there is another medicine called pirfenidone, which is used in fibrosing lung disease. And I'm not going to go into this all that much. It was industry sponsored, multi-center, et cetera, and same outcome measure, pulmonary function test, background therapy permitted, which is now sort of standard for most, if not all, of our clinical trials. The result was positive, but the FDA did approve pirfenidone, but it wasn't really tried in people with scleroderma lung disease, but in other forms of pulmonary fibrosis. So although there are times when it can be prescribed for people with scleroderma lung disease, it's not something that is commonly used. Well, what about the past 3 decades of scleroderma clinical trial research? Where are we? And I've been around for about the last 30 years of doing all of this. Well, we do have insurance coverage for cyclophosphamide and mycophenolate. Now, not all insurers may decide to cover it, but for the most part, it is covered. And we have FDA approval for Nintedanib and for another medicine that I haven't talked about called tocilizumab. Some of you may be on that as well. This is an injectable, a medicine that is also known as Actemra. It's used, and it was originally developed in rheumatoid arthritis, and now it's also used in scleroderma lung disease. Does not seem to help skin, but it's okay in lung disease in some particular situations. And we also have approval for a lot of drugs for pulmonary arterial hypertension, but that affects a relatively small percentage, fortunately, of scleroderma patients, but at least we have those medications. And there are multiple ongoing trials, both NIH-sponsored, investigator-initiated, and industry-sponsored in this previously considered untreatable fibrosing disease. So, is a clinical trial right for you? First of all, are you willing? And secondly, are you eligible? Even though you say, fine, I'm going to sign up for it. I understand that there may be side effects, but I want to be part of research. Well, we would thank you because you would be willing, but you might not be eligible. And cost considerations, and we'll talk about that a little bit more, But first of all, are you willing? Well, all studies have to be reviewed and approved by an institutional review board. It's not just a drug company, and it's just not just me or the investigator saying, oh, this is fine. We think we should try this drug in scleroderma. No. All of the data regarding the previous studies, the preclinical phase in mice, the phase 1 studies, and phase 2 studies, all the data have to be presented to the institutional review board for their approval, and only if they consider it safe and reasonably likely to be effective will it be approved. And all participants have to be able and willing to sign the informed consent form. And for those of you who have been in a trial, you know these can go on for many pages. It describes the study, the potential benefits, if any, the potential side effects, the risks, and the time commitment. And I have to emphasize this to you and to my patients that consent is a process, not an event. What we typically do, if somebody is willing and it seems that they could be eligible, we'll either give the consent form to them and have them take it home or mail it to them to read it at leisure, because as I said, it can be several pages, discuss it with their family members, think about it before they decide, yes, they're going to participate. Well, why volunteer? There are some potential benefits. You're helping others. If it doesn't help you directly, it may help others in the future. You get access to a new medication before it's generally available. And study-related costs are provided by the sponsor. But it's not just, say, travel costs and the time that you're here. It's also the time away from work for you or a family member. And it's in some ways a big deal. But what are the potential risks? If there are benefits, there are also risks. The medication may in fact not be effective, not be as good as I would like it to be or the company plans it to be. You may have side effects. And the time commitment is more than regular clinical care. I usually see patients every 3 months, sometimes every 6 months. But when you're in a study, you're coming back to the center, usually once a month, every 6 or 8 weeks. So it's more frequent than you would if you were just coming to clinic. And the sponsor doesn't cover the cost of routine care. If somebody comes in and it seems like they've got an infection, maybe a bladder infection, it's not part of the trial. So they would, I would ordinarily order a urinalysis, urine culture, prescribe an antibiotic, and it's not part of the trial, so it's not covered by the trial. But if you need blood work for the trial, it's covered. CAT scans, pulmonary function tests, all the trial procedures and testing are covered by the trial. So at least you're not out money. Well, there are a lot of ongoing clinical trials. Many are underway and recruiting, and many more are planned. Now, eligibility criteria vary. So not all people are eligible for all trials. And if you want to know more, there's clinicaltrials.gov will give you details, and any ongoing recruiting clinical trial will be registered with clinicaltrials.gov, and you'll be able to see potential benefits, potential side effects, etc. So this is a study summary cheat sheet, and this is what I am currently involved in, and there are other studies that are coming down the pike. So let's look at one. This is Horizon, and you may never have heard of a drug company called Horizon. They don't make a lot of medications. This is a phase 2/phase 3 trial, and they want to recruit 300 patients from a large number of centers. And each person is in the trial for a full year, 52 weeks. It's a pill, an oral medication, and it's given either once a day, twice a day, or the placebo. So it's randomized 1:1:1. So you have a 2/3 chance of being on the, quote, real medicine versus a 1/3 on being on the placebo. Well, the major inclusion criteria, you have to have had scleroderma onset, not necessarily diagnosis, but onset within the past 5 years. And you have to have diffuse skin involvement, which is to say there is thickened skin, not just of the fingers and back of the hand, but also the forearms, upper arms, maybe the trunk, maybe the legs. So what are they trying to prove? What do they think this is going to help? Well, the primary outcome measure is the change in pulmonary function test, primarily something called the FVC, or the forced vital capacity. So you can't be too bad. You can't have it at 45% at the beginning of the trial. And then once a month, we do pulmonary function tests covered by the study to see if it's better, worse, or the same. Well, let's go on to the next one, Prometheus, phase 2, 100 patients, again, a little over a year, but this is an IV medication, and it's IV versus placebo every, Prometheus is every month, every 4 weeks, 1:1 randomization, and again, less than 5 years and diffuse skin. And it's a phase 2 study, so they're not so much looking at results as they are looking at safety and annual rate of change in the forced vital capacity. So let's just go across here. So there are 2 oral studies that I'm currently involved in. Now, there are other studies being done elsewhere. There are 3 IV studies. We'll talk about this Chemomab one, and it's another drug company you probably never heard of. I was not familiar with it myself. This is 6 months rather than a year. It's an IV medicine because it is a monoclonal antibody, and those have to be given either by injection under the skin or by an IV. And in this situation, you get, again, a 2/3 chance of being on the, quote, real medicine. We don't know if it works, but hopefully it will, versus the placebo. And it's a little different in terms of the inclusion. For this, you can have had disease for 7 years or less, and not necessarily diffuse skin, about half limited, half diffuse. But there are lots of other criteria, both inclusion and exclusion for all of these studies. This just sort of gets you in the door. And after that, then it depends on your lung function, your kidney function, the other medicines you're on, whether some of the blood tests. So this is the screening inclusion. And then you're seen, and we do a lot of other work to see if you will continue to be eligible for this study. And some of the criteria are quite strict, so that most people just don't qualify. And this is the primary outcome measure, safety, tolerability. And then they're looking at some blood markers to see if those will change and improve on the IV medicine. Well, what's the current state of scleroderma clinical trials? We went over a lot of the history and all the trials I've been involved in for many, many years before we actually found something that worked and that seemed to be helpful without too much in the way of side effects. So what's the current state in 2023? Well, actually, the future looks bright for scleroderma treatment. There are multiple studies that are being done that have the potential for effectiveness without much, with less of a potential for side effects. So that really brings me to the end of my presentation. And I'm happy to answer questions. Let's see if I can stop sharing. Or Angel, can you?
Oh,
Or do I have to stop?
Let's see, I might be able to do that. Oh. Perfect. It should have popped off now.
Okay. Right.
Hello. Good to see you, Dr. Mays. That was a fantastic presentation.
Thank you.
Yeah. So we're going to open up the Q&A section. Please feel free to use the chat to put some questions. I do have some questions here now. So I'll go ahead and ask. Let's see. So we've got, who am I supposed to contact at a medical center to get information on what trials they're currently hosting?
Well, I think you can call like the rheumatology division. Usually there's a website. I know we have a website that gives you some contact information. But the other thing is the clinicaltrials.gov, which is, well, it's a government website, so it's not necessarily all that easy to navigate, but usually they'll list the participating centers so that people can just scroll through and find a place, the closest place to them, and then there should be a contact number, usually the nurse in charge of the clinic or the clinical trial research coordinator for people to either email or call and leave a message, and we can get back to you.
And that actually touched a little bit on another question that was here. Let's see. So are the same trials available at all scleroderma centers? What determines which trials available at each center?
Oh, well, for the pharmaceutically sponsored studies, they usually come to the scleroderma centers that are well known and have participated in studies before. And then that comes to me and I take a look at them and look at the inclusion and exclusion and decide if this is something that I am interested in doing and that it's likely that we can recruit patients for it. If we have too many trials, then there's competing trials, and that's not going to work. So you have to pick and choose. For the most part, most of the studies are available in most of the centers, but now that we're getting more and more studies, which is a good thing, then I think we have to be a little careful about deciding which ones. And although each studies I mentioned, they're usually a year. And then one of the studies that we're just embarking on will be 6 months for each patient. But these studies recruit up to a certain point. And when I tell a drug company, yes, I'm interested in doing this, and we decide on a budget, the university has a contract with them, we get everything up and running, then I am committed to recruit 8 patients or 10 patients. And once we've recruited that, then we'll continue to follow those patients and provide the medication, but we don't need to recruit any more, which means that we've got personnel and the clinic facilities available to start another study. So it's sort of a rolling kind of way to do things.
Absolutely. I can only imagine that and much, much more goes into the process, Dr. Mays. And another question here is, well, first we have a thank you so much for this wonderful lecture. Are the current state of clinical trials encompassing more studies focusing on Black and brown populations? They've been reading that scleroderma affects these populations differently.
Yes, that's true. In terms of frequency and severity, scleroderma can be more common in individuals, in Black and Hispanic individuals. recruiting usually comes from our general population, our patient population. And we do have, being in Houston, we have a fair number of minorities in terms of proportion of our patients. And there's no, to my knowledge, no increased recruitment efforts for minority populations. But I agree, it is a very important feature to include in clinical trials. We usually send out a letter to our to our physicians who tend to recruit or who tend to refer patients to us. And because of that, I think we cast a fairly wide net.
Thank you, Dr. Mays. And another question here is, if I participate in one clinical trial, can I still participate in another one?
Not at the same time. Yeah, you can sequentially. Once you finish one trial, you can go to another trial, but no, because then it would muddy the water in terms of trying to determine if the first study drug was effective or not. So no, not at the same time.
That makes sense, yeah. And this question isn't related to clinical trials specifically, but I'd be remiss if I didn't ask it. But they're asking,
yeah.
Can people with lung fibrosis get lung transplants?
Oh, yes. And that has been done, and that's timing it is always a tricky kind of thing. And then it also depends on the availability of a lung that is matched to that individual patient. But I know here in Houston, we at the University of Texas have a lung transplant program. There are other centers in the city that also have a lung transplant. I know they're around the country. There are places that do lung transplants in scleroderma. So yes, it can be done. You don't want to do it in some ways too soon because not all scleroderma lung disease worsens. Not all, fortunately, there's only a relatively small number of patients who become oxygen dependent. Of course, if you're one of those people, then it's 100% for you. But yes, you can be eligible for a lung transplant. It depends on a lot of other issues in terms of your health and in terms of your age, because it's, as many things, the older we get, the less likely or the less easily we can tolerate something like the really big surgery of lung transplant.
Thank you, Dr. Mays. And why do so many clinical trials only accept individuals who are early in their diagnosis?
Oh, yeah, I get this question a lot, and I wish it wasn't true. But the purpose behind that is they want to be able to demonstrate in the 1 year period of the trial that people have not worsened or that they've actually gotten a little better. And if you wait for 10 years or later, then a lot of the disease process has already happened, much of which may not be reversible, so that it looks like a drug is a failure, when if it had been given earlier, it would be a success. But frequently, particularly with Nintedanib, the lung drug, we looked at people with less than 5 years or less of disease. But once it got approved, we can use it in people with longer standing disease.
That makes a lot of sense. And I noticed in your presentation, one of the trials had that criteria for 7 years or earlier. Are you noticing, more trials are potentially doing that, increasing it maybe a little, or is that kind of an outlier?
Well, this is the first time I've seen that. It had been standard for many years to look at everything in 5 years. I've heard of another trial that is considering extending to 7 years. It's still in the planning stages. So yes, I think that people are looking at a longer disease duration in the hopes that they can show efficacy even in sort of longer standing disease.
Well, that's fantastic. I'm sure a lot of our listeners
Yes.
will be very excited about that because I do hear that question as well. Fantastic. And what happens after the trial is over? Can I still get access to the medication?
Yeah, typically, if it's shown to be effective and there's no surprising side effects, then there will be an open label extension with the drug company providing the medication for a set period of time. And actually with Nintedanib, that went on for 5 years. And then the company transitioned people because it was approved and on the market and covered by most insurers. The company just said, well, now you've got to use your insurance to get the medication. And if there was a problem with that, or if the insurance was just poor and there was a huge copay, then there was a patient assistance program. So actually, they did a good job of that. On rare occasions, I've been part of trials where the company has looked at the data part of the way through, which they typically do, to do an analysis. And they decide that it just is not working. And even if they continued it for the entire year, there's no way it was going to work. Or if they find a surprising side effect, then the trial gets shut down. And they say, no, it's just not going to work, it's too toxic. We're not going to continue this. So there are what they call interim analyses of the data, just to make sure. And there are data safety monitoring boards that are people, not me, the investigator, but other people who are experts in the field, who don't work for the drug company and who aren't an investigator, and they'll look at the data and they'll be able to say, oh, okay, looks pretty good. You may continue your trial, and or not. And most of the time they continue the trial, because by the time a drug gets to even a phase 2 study, it's been tested up one side and down the other.
That's good news. I'm sure folks are excited that they won't have to start and stop too often.
Yes, yeah.
And here actually related to that, what if I decide I cannot continue a trial? Will this hinder my ability to join future trials?
No, no. We've had patients who have stopped because they said, I have family responsibilities, I've got kids at home, I just can't come every month anymore. And that's fine. Or other things happen in their lives, or they need gallbladder surgery or something else comes up and it just becomes too burdensome, or they just don't want to continue anymore, or they move away. I mean, life happens, lots of things happen, and then that's fine. And people are withdrawn from the study, and no, that does not prejudice you or prejudice people from enrolling in another trial that perhaps is not as burdensome in terms of time commitments or others.
Thank you, Dr. Mays. And this is one from me. Are you noticing more clinical trials related to localized scleroderma by any chance? Is that kicking up in any way?
No, but then I'm not. That's not my area of expertise. It's hard to say. I'm a scleroderma expert, but I do systemic disease, and the dermatologists usually do the localized disease. But it's unfortunate because there really isn't much in terms of clinical trials. I know there's a lot of interest and studies, mouse studies, and a few small phase 1 trials that are being done, but I'm not aware that there are any randomized, open, available clinical trials.
Thank you, Dr. Mays. Yeah, that's just a common question I get a lot,
Yeah.
and I haven't been able to find much, so but thank you. And also, how is onset versus time of diagnosis distinguished when you apply for a trial? I guess, how do you tell the difference? Yeah.
Yes. Yeah. Well, as you can imagine, that tends not to be a hard date. People will remember when they were diagnosed, and we can get their medical records, and it's, you can tell. So the definition for many years has been the date of onset of the first non-Raynaud's symptom. So if people have had Raynaud's for 5 years, and frequently they'll say, yeah, it was at Christmas 5 years ago, or Thanksgiving or something, and I was out camping and I looked at my hands and I couldn't feel them, and the fingertips were white or blue. So that's the onset of Raynaud's. But then from that point on, when did their fingers first start to swell? When were they no longer able to wear their rings or had to get their rings resized? When did they start having trouble breathing, or they had a lot of heartburn when before it would be rare, and then suddenly it was every day, several times a day, trouble swallowing. So all of the other features of scleroderma, approximately when did that all start? And on rare occasions, people will start with puffy fingers before the Raynaud starts. But that's 5%. 95% of the time, we know when Raynaud's is. And then I know it's hard to find a rheumatologist. You go to your primary care doc and they say, oh, it's primary Raynaud's, don't worry about it. Or I'll send you to a rheumatologist, but there's a 6-month wait. So, there's that built-in delay. And I know then they go to their local rheumatologist who says, oh, it looks like scleroderma. I'll send you to Dr. Mays. And then it's another 6-month wait. So it's frustrating. And there are actually now 3 of us, myself, Dr. Asasi, and Dr. Skog, who are seeing almost all scleroderma patients. So we've managed to increase the new patient slots, but there are still more patients than we really can see in a timely fashion.
Of course, but that's fantastic that growth is taking place.
Yes.
I know I get a lot of phone calls from individuals across the country that want to fly out to see you and the team. So that's great news. Yeah. And in talking about that, is there any tips or anything you'd recommend to folks who live in a state that may not have a scleroderma center and they want to get to one of these trials? Are there any inclusion/exclusion criteria or anything like that may hinder them from doing so?
Well, yeah, I think the first thing to do is to go on the clinicaltrials.gov and find maybe a couple of places close to you, and then contact them. And what we typically do here, my research nurse, Pat, will arrange to get the medical records sent. And then she asks a few key questions. So when were you diagnosed? When did the Raynaud's start? So we get a general sense. And then we get their medical records. She does the first review. She gives them to me. I do another review. And we're looking for sort of the big things. And a lot of the exclusion, it depends, is there significant kidney disease or significant lung disease? What medicines are people on? So we can determine fairly quickly from a review of the medical records, especially the rheumatologist record, if somebody is likely to be eligible. And if that's the case, we can bring them in for a screening visit. But, we don't want to offer hope or have people travel an extended period of time, just to say, well, no, I've looked at your records and there's no way you're going to be eligible for a trial.
Okay, that makes sense. And I have a couple questions here that are a little bit more specific, but one asks, is there a study taking place that you know of for reversing lung fibrosis?
The answer to that is no. One of the problems with scar tissue is that once it gets laid down, and once the collagen that forms the scar cross-links, there's very little that can dissolve that can put that away. In early lung fibrosis, before, when you've got collagen laid down, but it's not cross-linked yet, then that can be reversible. But once it's well established, no. But I've seen people with lung function improve, and you think, well, scar tissue, how can that happen? It's because it's probably early scar tissue. And it doesn't go down to 100%. I mean, it doesn't reverse to 100%. But at least what we hope to do with our medicines is that it stops the progression, or at the very least slows the progression. And in some situations, we can cause a little bit of reversal, but it's really too much to ask to say the scar tissue is going to go away.
That's a very important distinction to make. Thank you. And another one is, are there any studies taking place that are trying to discover what causes scleroderma?
Oh, yes. Oh, yes. Yeah. I'm on the clinical trials side now, but on the lab side, we are looking at several mechanisms, mostly for the immune system, and for that part of the immune system that talks to the fibrosing system, to see how can we interfere with that. And the question I've asked for more than 30 years is, what is the trigger? I mean, people go through life, they're in their 30s and 40s and they're fine, and suddenly mid-40s or 50s or even 60s, then they have Raynaud's, then the hands start to swell. What is the trigger? What caused that? And we've looked at genes, and there are some genes that will increase the probability or the susceptibility, but there is no gene or combination of a handful of genes that really causes scleroderma. And you sort of know that because it's not a childhood or young adult disease, although it can occur in childhood, but still it tends to be more middle age, people who've gone all their lives and never had problems like this before. It's a huge puzzle, and I would hope I have some sense of what causes it before I die.
No, if anyone's going to find it, it's going to be you or one of your close colleagues, Dr. Mays. And another question that's a little bit more specific is, do you have any thoughts on stem cell transplantation in scleroderma?
Yes, yeah. I was part of the Scott trial. I didn't talk about that, but yes, for people who have early diffuse, and again, within 5 years, who already have some internal organ involvement, usually lung, then the protocol, which is, the full name is high-dose chemotherapy followed by stem cell rescue. So it is full-dose chemotherapy. People are admitted to the hospital. The medication, cyclophosphamide, anti-lymphocyte medications, a little bit of radiation. It destroys their own bone marrow. And prior to that, they've been on this pheresis machine that removes their own stem cells. They're purified, they're frozen away. And then after the bone marrow is destroyed, then the stem cells are reinfused back into the patients. And the reason we use their own stem cells is so that the body won't reject it. There won't be a graft versus host disease, which is dreadful and difficult to control. I think I know I am referring fewer people to MD Anderson Cancer Center, which is in Houston down the street from us, for that process, because we've been able to improve people on the mycophenolates and some of the other medicines we have without resorting to the stem cell transplants. There is a certain number of people who don't survive. There's about 3% mortality rate associated with the treatment, and it's because there's that period of 3 weeks to 4 weeks when people don't have a functioning immune system. And we don't have, even with all our fancy antibiotics and antifungals and antivirals, people can become infected and just not, and never recover from that infection. So yeah, I think it is helpful in some situations, life-saving, but it's something that you have to think about very carefully before you embark on it.
Thank you, Dr. Mays. And we've got just one last question. The question is, have you seen patients where their hands and feet begin to shrink? Is this a good sign or a bad sign? I know this isn't covered, but thank you so much for your time.
Yeah, well, if the hands are swollen, then the swelling can go away over time. If that's what they mean by shrink, yes, yeah. And sometimes people lose the subcutaneous fat, and you think, oh, my fingers aren't fat, how could they get thinner? But with the lack of blood supply from Raynaud's, that even that small that small amount of fat in the fingers and in the hands can dissolve away. So it looks like the fingers are much thinner. And I've talked a lot about puffy hands, swollen fingers, but the feet can be swollen, can develop swelling as well. And then as time goes on and as the disease is treated, then that swelling can go away. So it sort of looks like the feet are thinner.
Thank you, Dr. Mays. This was a very active Q&A session. Thank you so much. Pretty much brought us right to the top of the hour. With that, do you have any parting comments for our attendees and those who will be watching this at home?
Well, I'd just like to express my gratitude for all our patients who have volunteered to be in our clinical treatment trials. I think they're the real heroes.
Thank you very much, Dr. Mays. And with that, I want to thank everyone who's in attendance. I want to give you a huge thank you, Dr. Maureen Mays. I also want to thank the sponsor for this event, Lars Therapeutics.